angioplasty and stenting has been done on dual antiplatelets. He also has pectus excavatum with moderate restrictive lung disease, and he is having severe pulmonary hypertension. Pre-op cardiac status on echo, he is having a akinetic LAD territory with a biventricular dilatation and failure. LV dimensions were 68 and 48 mm with RVS FAC of 25% and a grade 3 diastolic dysfunction. He also has a moderate MR and moderate TR with a global systolic dysfunction, severe PAH with RVSP of 80 mm Hg, almost 70% of the systemic pressure. Pulmonary, he was having pectus excavatum with a restrictive lung mechanics. So he was having reduced FRC with poor compliance, high risk of hypercarbia and hypoxia. So there is a severe PAH. So he was also having a risk of acute RV failure. So preoperative status, patient was having exertional dyspnea with limited functional capacity, optimized with post-dialysis uremic status, and he also having anemia of CKD with 8.6 and normal electrolytes post-dialysis, persistent high PA pressures even after dialysis. So what are the major perioperative risks? I think can discuss with this. Key doubts in managing these patients. I think I'll open this discussion to the panelists. Can this patient safely undergo renal transplant? Can any of the panelists discuss on this?
The first question is this patient a candidate for renal transplant? He's got severe LV as well as RV dysfunction, plus renal failure, diabetic. So,
whether he's a candidate for renal transplant?
For renal transplant is what's my question.
Or he is a candidate for both heart and renal transplant?
So cardiologist, if this patient, you put a new kidney inside him, will that kidney function with severe LV dysfunction?
Yeah, the same thing we discussed with this case a few days ago, whether this patient is really fit. But then just I asked post-operative course and all. See, whatever dialysis and whatever, the patient was doing well for quite some time. So after the procedure, because it's a double insult, and then once you do this, the RV dysfunction, whatever it is, it may not progress or it may at least halt. The most important reason is he was quite young relatively, right? He was around 45 years. 45 years. That was the main reason to give a chance and then see with the people. Otherwise, the mortality, if it is more than 1 year, we can probably give a good quality life. That is the reason.
Suresh? We did a couple of cases with this almost same scenario with a severe PAH. The first case I was literally worried. I also asked the nephrologist and cardiologist, will he come out? But to my surprise, once the kidney started functioning, the RV pressures will come down. I put a PA catheter in this type of cases, PA catheter in the before induction itself, continue it into the post-operative period. As of course, they will be on the anti-PH medications also like tadalafil and all. We continue that into the post-operative period, but it comes down. If the kidney is functioning well, the PA pressure tends to come down. Even LV function also improves. That's cardio-renal.
Yes. The second question is on table. Once the kidney is placed, you have to give lots of fluids to the patient. And he's already got severe pulmonary hypertension on the verge of RV failure. So, will that tilt the balance during the intraoperative period?
Kidney starts functioning and pouring out adequately rather than having imbalance and then intermittent dialysis where there will be a lot of fluid shifts and all, where the insult will be more on the RV function. If it functions well, pours out a lot of urine immediately, that will definitely reduce. That's what we thought. And age was the only factor. In fact, we had a discussion about this case a few days ago. Was it really? Then age and then, some cases do respond after this. So it happened, and patient was leading good quality life and for quite some time.
So another question will be, how to manage the RV collapse during induction and intubation, which are triggers of catecholamine release. So that is also one of the concern in this patient. So how to manage the SVR PVR balance? It's a question to anesthetist panel.
Inhaled prostanoids, have you tried to reduce transiently the pulmonary arterial pressure?
How about 100% oxygen, sir?
Yeah, it may help to some extent, but inhaled prostanoids are indicated in such cases to transiently reduce whenever there is an acute insult in PIH.
And theoretically, at least, my concern would be that, see, you have RV, severe pulmonary hypertension, you reduce the pulmonary vascular resistance. On the other side, on the left side of the heart, you have a failing heart. You are going to get more transpulmonary flow of blood. How will the LV accept this just before the transplant I'm talking about, during induction? So if you use inhaled nitric oxide or prostanoids, as he mentions, you reduce the pulmonary vascular resistance, there is increased transpulmonary flow of blood. Is the left side going to accept this additional blood flow?
This is an ideal case for the paraoperative transesophageal echocardiogram, where you can clearly see the preload and then the afterload and then dimensions of the vessels. So you have to be very, very cautious, and then closed loop fluid management in such a case would be better.
And what would be the ventilation strategy in this patient? How to ventilate with, provided the dynamics of RV, LV will fare with the positive pressure ventilation, but RV will not fare with the positive pressure ventilation. How to maintain the tidal volume and PEEP, and how to maintain normoxia, and how to prevent hypercarbia.
I think the present strategy would be to use protective lung ventilation, use 6 ml per kg and a little higher PEEP. That, see, the PEEP will not be adversely affecting the pulmonary vascular resistance, because many of these patients will be having a lot of pulmonary congestion or pulmonary vascular, and pulmonary vascular resistance is least when we have the best PEEP. So you have to titrate your PEEP and use protective lung ventilation. That would be my strategy. I don't know how others would like to do. Are the other anesthetists in the group? Raju, Mahesh?
Yeah, I think Suresh, what you said is right. I think the trick is to use the moderately low tidal volume, moderate to low tidal volumes, and ensure that you also accept a little bit of hypercapnia. You don't need to really be too much worried about it. I'm not saying
What
60
will
or
be the
65
target
plus.
PaCO2?
Pardon?
Target PaCO2?
Yeah, maybe up to about 50, 55. Shouldn't be a problem in this case to an extent. Because what would probably hurt the RV is the high tidal volumes and high peak airway pressures.
So plateau pressures will try to
Plateau pressures also, yes.
come.
Limit to about maximum of 20 centimeters.
25 can accept.
Yeah.
Yes.
Yeah, we can proceed, Dr. Loganathan,
Yes.
so we can have questions.
So based on the discussion, so in this case, what were the physiological priorities were to maintain the RV perfusion? So maintain the MAP of 70 to 75 and avoid increasing in PVR. So we should avoid hypoxia, hypercarbia, acidosis, and also hypothermia. And we should avoid excessive PEEP, and we have to maintain a sinus rhythm to maintain a RV preload. So atrial kick is very important in RV, and heart rate control is also important. For graft and renal perfusion goals, we have to again maintain MAP, and we have to avoid hypotension, long periods of hypotension during reperfusion phase, and dynamic assessment of fluid responsiveness, and we have to prevent acute RV decompensation. So how we manage this? We have placed IV line, arterial line, and a PA line before induction, and we have induced with ketamine, low dose ketamine with a fentanyl of 3 mics per kg to avoid the tachycardia by ketamine. And we add a lung protective ventilation with low tidal volume with moderate PEEP, and we maintain normoxia. We avoided hypercarbia, maintained an PaCO2 of 35 to 40. And we have carefully titrated the volatile agents. And volatile agents, isoflurane was kept at 0.8. And careful titration of anesthetic to balance the bioventricular function. Maintain MAP of 75 to 85 and balanced fluid. So we avoided overload and maintained a narrow margin based on the PA pressures and pulmonary capillary wedge pressures. We didn't have TTE, so TE, we had TTE, transthoracic echo. So based on that, we had fluid management. Intraop, we have used a low dose norepinephrine. Post-operatively, there was a little lactate rise with a low mixed venous saturation. So we have kept a dobutamine for a day. Post-operative patient extubated after 6 hours, and he was doing well. Discharge after 16 days, and follow-up echo also was showing decreasing TR gradients, that is decline in PA pressures, improving RV function, and LV dimensions after 2 months were 58 and 43 mm. So though there is a improving cardiac function, patient unfortunately expired because of neutropenic fever and sepsis after 2 months of transplant. Thank you. Anything?
Thank you, sir. For third case discussion is perioperative Takotsubo cardiomyopathy by Dr. Ram Manohar, sir, consultant cardiologist from Aster Ramesh Hospitals. We welcome you.
Good afternoon, one and all. So I'll be speaking about a couple of cases of Takotsubo syndrome, especially pertaining to the periop period, which looks like an MI but behaves like a mystery. So poetically speaking, when ECG says MI but coronary says no, it's Takotsubo. So I'll speak about both the cases, and then we can have a couple of questions for discussion. So the first case was a young female, 25-year-old female without any risk factors. 3 years before the current presentation, she had a fall for which calcaneal bone as well as spinal fixation was done. And then she was taken up during the current admission, before to our admission for implant removal in an outside hospital under spinal anesthesia. Patient developed hypotension in the intra-op period for which she was managed with inotropes. But she later on, immediate post-op period, she complained of chest pain and shortness of breath, and also had hypotension again, for which she was treated with adrenaline, noradrenaline and dopamine, and then shifted to our hospital for further evaluation. At presentation to our hospital, she was hypoxic with hypotension, and she had bilateral crepitations with a wet lung, and troponin and NT-proBNP levels were significantly elevated. The ECG showed significant ST depressions in all the leads, with subtle elevations in one AVL and AVR. X-ray, as shown, has pulmonary edema, and echo, as you can see, has severe LV dysfunction with EF of some 15 to 20% with global hypokinesia. Immediately, we have placed an IABP in view of her shock as well as suspicion that it could be Takotsubo. There was transient improvement initially with pulmonary edema, and the X-ray seemingly improved a bit. But by the time she reached our hospital itself, she had multi-organ dysfunction in the view of AK and decreased urine output. Though there was transient improvement of pulmonary edema after IABP, she had worsening of cardiogenic shock and end-organ failure with oliguria, and the patient succumbed after day 3. There are a couple of questions pertaining to this case which we'll discuss later. So I'll move on to the second case, where again a young female underwent laparoscopic salpingectomy at an outside hospital. She developed class 4 dyspnea immediately after the surgery, for which she was intubated and was referred to our center. Again, she had tachycardia with hypotension and bilateral diffuse crepitations. ECG again showed sinus tachycardia with subtle ST depressions. Echo showed a global hypokinesia with severe LV dysfunction of ejection fraction 25%. Again, similar to the previous case, an IABP was inserted and she was stabilized with intubation as well as IABP. Coronary, gradually her hypotension started improving, and on day 4 of admission, since it was new onset LV dysfunction, and we wanted to rule out a coronary event, and a coronary angiogram was done which showed normal coronaries. Over the period of total 5 days, her tachycardia settled, hypotension improved, and her LV also started improving. And by the time of day 5, she actually had an ejection fraction of 55%, and she was later discharged home walking. So these were the 2 cases of probably suspected Takotsubo. I would not call them typical cases because they are not postmenopausal females as we typically encounter. They are young females. They had physical trigger, not the emotional trigger, which is traditionally said so. They had global hypokinesia and not apical ballooning. Both of them did not have any elevations ST elevations are considered a significant thing in Takotsubo, not ST depressions. And there was an initial response to IABP, but unfortunately, since the first case came in a bad shape to our hospital, we couldn't salvage her. So there were, these were the two cases where the presentation was not very typical, but the clinical picture and the overall scenario fits into the diagnosis of Takotsubo. Though we know that premenopausal females account for only 10% of the cases, younger patients actually do have an atypical presentation of Takotsubo with a fewer comorbidities, and they also have more likelihood of having a neurological or psychiatric issues, and these patients have a higher rate of in-hospital complications than the typical Takatsubos do. So we all know the triggers and all. I will not, because of the want of time, I'll probably directly skip on to the cases and the questions. So the questions which we wanted to discuss in these cases are whether an early recognition of these cases versus a delayed diagnosis would help these cases. So we all know that the peri-op event is mostly an ACS. Takotsubo is a rare thing, but one should remember that Takotsubo has a similar presentation irrespective of the age. So every unexplained intra-op hypotension should trigger a suspicion of Takotsubo in addition to the usual acute coronary syndromes. Just for the panel members, we just wanted to know how many cases of ICU or OT related unexplained shock later on turned out to be Takatsubos and not ACS or something else. Any experience with the panel? Yeah.
Once we did a major procedure in Ramesh Hospital. Of course, she is an elderly lady, around 75, 80 in between. And then we did a, laryngopharyngectomy for that patient because she could not really swallow anything. At the time of surgery, after surgery, she landed in Takotsubo.
Takotsubo is not an uncommon thing. We see it, I've seen at least 5-6 cases in my life.
Yeah, recently we had one case of a second stage cesarean section who had massive PPH, so intra-op hypotension managed with inotropes. Post-operatively, when we were giving blood transfusion, she had a sudden onset of shortness of breath with aggravation of the hypertension despite being on 2 inotropes. So we were in a dilemma whether it is a transfusion-related reaction or PPCM or something. We did a POCUS, there was global hypokinesia. Cardiologist was called in and he put in a diagnosis of Takotsubo, shifted to the cardiac care. And I don't think an angiogram was done for her, but the cardiac function recovered within 1 week. And as in the second case, she was discharged walking within a week. And within a month, her EF is back to normal.
So just to emphasize the fact that many of us would have encountered cases which are not typical. So Takotsubo, probably it's evolving. The entity has been officially recognized only in 1990. So probably we do see a lot of atypical cases which are being missed. So moving on to the second case, one thing which we all know is catecholamines are the cause or the presumed cause of Takotsubo. So are catecholamines worsening the pathophysiology of Takotsubo, or should we really use adrenaline dopamine in these cases? And what do you prefer as the vasopressor of choice in these cases who have shock?
I think one of the important things is that, all anesthetists should know how to do at least look at the echo. And once we diagnose a case of Takotsubo, they call it reverse Takotsubo also is there, where the base doesn't move and the apex moves. So once we make a diagnosis, one of the first things that we do is take off all the inotropes and we use levosimendan or milrinone to offload the patient. That is one of the important things that all of us have to do.
Is there any guidelines to call it as Takotsubo?
Sir, yes, sir. There are multiple diagnostic criteria to say the same, but all of them mandate ruling out any coronary event. Because again, having said this and these all, if you see a peri-op event, it is mostly an acute coronary syndrome. So it mandates that you rule out an acute coronary event by doing a coronary angiogram and rule out that there is no plaque rupture or any thrombus in the coronaries. So having said there are
can't it be a viral cardiomyopathy at that time?
Happening on table is something which is very unusual because they were absolutely normal pre-op.
We will not be damn sure whether it happened on the table or just immediate post-op scenario.
So, at least both these cases were intraoperative. It would have evolved over time, sir, if it had been a viral myocarditis.
Yeah, there are two aspects of this. One is The definitive diagnostic criterion is cardiac MRI, where you find only edema.
edema.
There won't be any infarct or fibrosis in Takotsubo, number one. Number two, the catecholamines and all nowadays, I think Dr. Praveen Kumar will be talking about personalized pain management. Hypothalamus pituitary adrenal axis is increasingly being discussed, wherein the glucocorticoid receptors and the mineralocorticoid receptors, there is imbalance in pathology. And when the patients are very anxious, pain, all these areas, now more focus is being done rather than routine opioids and all. So I think sir will be talking, and it's an interesting aspect. Both the patients, in fact, I took the history even 4 or 5 years ago also. She was very anxious for 3-4 days even before getting admitted. That's what we got the history. And even this lady, the removal, before that she was quite anxious for 3-4 days. She avoided the doctors. That's what the attendants said.
Higher rate of psychiatric or neurological things are seen in these younger atypical patients. So with regard to the vasopressors and all, usually it is said that some cases you might not avoid catecholamines altogether, because if there is refractory shock, you will have to give, but at least have a bedside echo frequently and see whether the patient is developing LVOT obstruction. So if the patient is not, then probably catecholamines in a guarded way is something which we can consider. And if there is significant LVOT obstruction, yes, beta blockers and judicious use of IV fluids is something which can be helpful. And the third thing, in both the cases we have put IABP, so probably sir would be the best person to say. So IABP in cases of Takotsubo, what do you think, sir?
Literature doesn't say much, but extreme sympathetic activity, vasoconstriction, it is not a septic shock. So IABP with severe LV dysfunction, 15-20% would definitely benefit to tide over the crisis. As soon as it improved, I think within 24-48 hours we removed it.
Yes, sir.
In Takotsubo with LV obstruction, IABP is contraindicated again.
That's what the same discussion we had when we had this. So see, the patient is admitted in ICU and we frequently do see the echo. So if the patient is developing some sort of LVOT obstruction, definitely we'll consider de-escalating or weaning the IABP. Till that point of time, yes, there is a role of IABP.
In hyperadrenalism, there will be pseudo LVOT obstruction also. So it's very difficult to differentiate.
And the last thing to the anesthetist, so we, just to speak, there was an international registry on Takotsubo which says that emotional triggers are the most common. Traditionally it was thought so, but now more and more physical triggers were found to be the most common cause of Takotsubo. So we all know the matrix where every phase can trigger a Takotsubo, where the pain or anxiety can do so. So my question to the anesthetist would be, what choice of anesthesia do you think is safer? If the patient is already a known case of Takotsubo, or in general to avoid Takotsubo, and any specific techniques or tips or tricks in a case who is already known case of Takotsubo?
Can I say something, Suresh? Dr. Ramesh? Dr. Mahesh here. I think a couple of things. One is when we talk about a classical Takotsubo, I think it's basically very centrally mediated. That's a very classical, typical presentation. All those atypical presentations that you're looking at right now, what you presented in a couple of cases, are predominantly probably atypical. I think they're all, in my opinion, I know we can probably group them under Takotsubo, but I think it's predominantly evolving at a stress cardiomyopathy. Yes. Predominantly, not the classical.
Not the classical ones.
But it is on the myocardial oxygen supply demand issues that are there perioperatively. I think they give a temporary scenario of a cardiomyopathy where the myocardium is completely depressed because of the oxygen supply demand issues. So as an anesthesiologist, it is very important for all of us to understand how do we maintain, even if there is no issue with the coronaries in terms of the myocardial oxygen supply, but I think it's important to maintain that oxygen supply demand, as every anesthesiologist's prerogative have been say very prime importance. It's a prime responsibility for all the anesthesiologists to ensure that we maintain those oxygen supply demand in the perioperative period, especially in high-risk cases like what Madam is talking about. We see very often, it's very difficult for us to differentiate between a postpartum cardiomyopathy syndrome, and we see fair bit of LSAS getting into trouble postoperatively. So I think it's important for us to differentiate. It's not easy to differentiate between a postpartum cardiomyopathy or a stress cardiomyopathy scenarios in LSAS. Again, the same issue in LSAS. Very often, suppose if they're coming out from a difficult labor, into an emergency LSCS, they are subjected to multiple durations of multiple hours of tachycardia, and then they are coming into the operating room, and then we probably anesthetize them with general anesthesia because there's a fetal distress or a fetal bradycardia. All that scenarios lead to a stress-induced cardiomyopathy. I think it's important for us to maintain the oxygen supply demand as anesthesia officers.
Can we use preoperative anxiolytics? Maybe most of the guidelines may not recommend, but what is the role of, since it is an emotional, one is the most
Dr.
triggering
Praveen
factor.
Kumar will talk about pain and anxiety. Let's talk.
So the anesthesia choice, probably it's not the choice which is important, probably it's the principle and how well you do the anesthesia. So I'll just speak a couple of slides. Why is it important to recognize? Because the management is different. You reduce the catecholamine dose if it is a Takotsubo related shock. Watch out for more frequently watch out for LVOT obstruction, and probably you'll consider IABP. And also you unnecessarily will not thrombolize the patient because the patients most often present with ST elevations. And if treated in time, they have good prognosis. So the key takeaways are, not every peri-op MI is plaque rupture. So ST changes, troponin rise and shock need not be acute coronary syndrome by default. Stress cardiomyopathy is a real peri-op entity. The trigger is iatrogenic in these scenarios, could be emotional, but also iatrogenic. So a smooth anesthesia is something which is very mandatory. And catecholamines in these scenarios are a double-edged sword. And echo obviously beats ECG here because ECG might mislead us into an ST elevation MI. And shock physiology matters more than the label because treat the hemodynamics first. Probably the labeling of Takotsubo can be done later because here mechanical support and reduction of catecholamines are more important and not escalating the inotropes. And recovery can be dramatic in most of these patients. And the early recognition salvages the myocardium, and delayed diagnosis might lead to a irreversible damage, just like in our first case where the patient already developed multi-organ dysfunction. Thank you.
Thank you, sir. Thank you, panel members, and thank you.